Thank you, Rohan, for the introduction. Probably I can proceed faster with some cases. Uh, my brief is on close treatment of dorsal dislocations. Dorsal dislocation, as you have just seen, they can be pure dislocations. They present early because they are very painful. They have grotesque or gross deformities, and they are very obvious on radiographs, so cannot miss it actually. And as you can see, these are gross deformities, they are very painful, they present early. The problem is these fracture dislocations. They are generally missed on X-rays. You require multiple X-rays, AP, lateral, obliques, and you require a lot of suspicion. You have to take a proper history. Generally, cricket ball, football injuries are the cause of these problems. And they are generally diagnosed, or the seriousness of this injury is diagnosed on dead lateral views. You can, many times they don't present early, many times the injuries are missed, the patient has gone to a GP or not gone to any doctor at all. If he has gone to a doctor, X-ray is not taken. They generally don't have any obvious deformities. As Rohan said, that we should be very suspicious if the patient does not have complete flexion or does not have flexion at all. Then you have to take X-rays in such cases. So I'll just run through a few examples of PIP dislocations who have presented early. Generally, these are pathognomonic. This deformity is very pathognomonic. These dislocations they come into OPD, and you can literally reduce them without any anesthesia. You just talk to him about the history, and by the time you just have pulled the finger, it is reduced. And the patient becomes very happy. You can see, in spite of this wound, hardly any time to clean the wound also, but the patient is having full flexion extension. What you have to remember in these cases, these are generally extension injuries or hyperextension injuries. If the patient is not willing for a splint, generally they are very happy. They say, "Kitna paisa ho gaya, batao humko jaane ka hai." They are so happy. So you just prescribe some drugs to them. Insist, or if the patient is amenable, just give him a splint in flexion or prevent extension of this joint. For 2 weeks it is enough. Let the soft tissues heal, and then the patient will never come back to you. Most of these patients have not come back for follow-up. So avoid or prevent extension for 2 weeks, and that's enough. This patient is probably a severe example where there is a buttonholing of the proximal phalanx. Here, there is also no need for you to take him in the OT. All you require is cleaning up properly, because joint is exposed. So clean it up properly. Just expose it with a local anesthesia. The flexor tendons are the cause of this thing being irreducible in the OPD. So just take it under local anesthesia, lift up the flexor tendons. This will reduce, and the patient will have a good result. Remember, all these patients will, if they are neglected, if they don't come to you for follow-up, or if you have not warned them, they will all have flexion deformities of the PIP joint to varying extents. Depends on how well they have followed up and how well you have treated the patient. So we come back to that index case where there is a sports injury, there is minimal pain, there is incomplete flexion, and there is a swelling of the joint. The X-rays have been ordered, AP lateral lelo. Generally the technician takes AP oblique because patient is not taken, or you have not insisted on the finger X-ray. You insist on the X-ray of the involved finger, not of the hand. So diagnosis missed on random views. Insist on a lateral view, 2 laterals if necessary. Don't waste your time on APs and obliques and all that. So this is the lateral view. This tells you that there is a small flake, there is a volar plate injury, joint is subluxated. It is not a pure dislocation, a fracture dislocation. So here a dead lateral view is essential, mandatory, imperative, whatever word you want to use. The treatment depends on the time elapsed since the injury. If the patient has come to you immediately, which is very rare, so it depends. You can just treat it with close reduction. And the articular involvement, I would not grade it as 50%, 40%. It is of no use. It depends on stability. So what you have to see is this concavity. If this concavity convinces you that this joint is amenable to a close reduction, treated by close reduction, I know what I am going to speak. Pankaj doesn't like it. I keep the joint in 90 degrees flexion like this. I keep it in 90 degrees flexion for 2 weeks because I know how to treat the flexion contracture that is going to occur. If you know how to treat the flexion contraction that is going to occur, you can treat these fractures by closed means. You can, after 6 weeks, you can give him a Kapner splint and your PIP joint contracture will get corrected. So this is a very simple thing. Now the amount of traction you require depends on how stable is the joint and how early the patient has come to you. So if this patient has come very early, you just require simple traction. In fact, this traction just serves as a method to remind the patient to keep the finger in flexion. This traction is not doing anything great. You can see there is hardly any traction on that rubber band. But it convinces the patient or ensures that patient keeps the joint in flexion. If the patient is cooperative, amenable and comes for follow-up, I ensure that the joint is stable after 2 weeks by taking an extended flexion extension. It tells me that the joint is not going to subluxate further, and then I start mobilizing him. And the PIP joint contracture, if it occurs, if it is stiff, I give him a Kapner splint, or you can correct it with a dorsal gutter splint also. But you should see that you should not give this splint before 6 weeks, which is a very strong splint. So you can treat it with a dorsal gutter splint, which is not a dynamic splint, after about 3 weeks. And that's the function. So many times, after reduction of these joints, this joint was well reduced by closed means, but the surgeon did not insist on flexion. So this patient landed up with an incomplete flexion after the reduction of the PIP joints. For this, also I have designed a splint that is a passive stretching of the finger in flexion with this rubber band splint. And that is how the patient is doing exercises of the finger in flexion and extension with this rubber band, and eventually gets a very good result with this simple splint. So we have seen a flexion contracture, we have seen an extension contracture following PIP joint fracture dislocations. So now this patient has presented very early. This was a radiologist who just refused to have any sort of splint. He said, I'll keep the finger in flexion voluntarily day and night for 2 weeks. He did it. And you can see this is on the 23rd day. The fracture is absolutely stable. This is 6 months. This is 2 years. And excellent result with close reduction. But voluntarily is kept in flexion. No rubber band, no splint, nothing. But that I cannot trust everybody, because this fellow said, I will send you an X-ray every day. I have my own, if you want. He's free mein hai na, X-ray. So again, in a lateral view, if you are convinced that this concavity is good, this is a good prognosis with close reduction. So in this case, I have used a slightly stronger rubber band, a stronger splint, to ensure that patient keeps it in flexion. Flexion contracture did occur. I corrected it with a Kapner splint, and this patient came after 12 days. So in this also, I was convinced that this could be reduced with closed means. And you can see that this concavity is good enough for me to keep it in flexion. However, I used a very stronger splint. Now, in this case, a nail traction is not good. The nail will get a lot of pain if you use a nail traction. So I use a sticking plaster on the finger and just stick it into flexion, keep it in flexion for 2 weeks. And this is an X-ray taken after 6 weeks. This is before splint, before I apply a Kapner splint. And that is the X-ray after 5 months, a complete restoration of the joint and function after 5 months. Should I stop, Rohan? No, I have got a few examples where patient have presented further after 3 weeks. So in this case, because my brief is on treatment of close reduction of this method, of these fractures, this patient has presented after 3 weeks. That is the ideal time for these fracture dislocations according to me for presentation, because the fracture is very sticky. All you have to do is just put a distractor, just pull it, and after 4 weeks you remove the distractor and ask the patient to just flex it. And of course, you take serial X-rays, and this is a 16-year follow-up of that same patient with, you can see, excellent function. This patient has presented for 6 weeks. Now, I know that the joint replacement or hemi-Hemate arthroplasty is a very good method for this. But what I have seen in practice is that even after 6 weeks, 2 months, or even 3 months, this small Vorer plate, this small fragment here, is not united. What you require is an external fixator just to pull out the bone, pull out the middle phalanx against the proximal phalanx. This fracture, this restraining volar piece will come back in place and form an excellent concavity and give you a reduction without opening the fracture. Sorry. Yeah. So that is the 6 weeks post injury. That is the external distractor. When the external distractor is in place, you ensure that patient is performing active flexion and extension of the DIP joint. Sorry. Yeah. So this is the immediate postoperative X-ray. You can see that this fracture is got pulled out here. That is 2 weeks post-op. At 4 weeks, you remove the fixator, you don't remove the K-wires, and take a lateral view. In the lateral view, if you see there is no subluxation, you can remove the fixator and start him movements. You can see that this volar piece has formed, restored that concavity, prevented a subluxation, and you can see this is a very good function at 6 months by closed means. Another patient presented 2 months post-operatively. The fracture looks united. There is no reason to suspect it is not united, but in practicality, this fracture is not united. With a distractor, you just pull out the middle phalanx and you can see that this fracture opens up, because the reason I think is that the volar plate is so strong that it resists the force of this fixator and pulls this bone down. And after 4 weeks, what you have to see is the lateral view. If you suspect a subluxation, don't remove both the K-wires. Keep the distal K-wire here. And that K-wire, you can bend it like a hook. And again, use a rubber band to bring the finger back into flexion. All it requires is slight molding of that joint back again. And you can see at 6 weeks, this articular surface is molded back. The fracture which we thought is malunited has gone back and the joint has reformed again. Sorry. And this is 1 year post-op. You can see this flexion and extension views. If the patient follows up, you get time and occasion to take lateral view in flexion and extension, which convinces you the joint is well formed and stable. And that is the function at 1 year post-op. This was an old injury for which it did not require or did not want to get treated. I thank you all for your attention.